So most of my slides will be repetition from previous speakers, but why do you need calcified lesions to be treated and be aggressive upon it? First of all, we don't know. Many of the patients ask us why is this calcium there in my blood vessels? So we don't have any answers, but I think aging, diabetes, chronic renal disease, hypertension, smoking gives rise to increased calcium. That's what the data says. So new technology for treating high-risk patients would be CHIP, pre or post TIVR, PCI and post CABG patients. So the treatment of calcified lesions will continue to grow over the next decade. So what is the impact of calcium? It causes suboptimal stent expansion. There's a device delivery failure if you don't prepare these vessels properly, and there's increased complications. So algorithm has already been, this was shown by Dr. Ajit Menon in his slides, initial slides, that some of this, there are plenty of algorithms which I think Florim disagrees, and let me tell you this, the more the numbers, the more the calcium volume index increases, angle more than 182 points and thickness and length, all of these things will lead to a situation where you have to plan your modality well and execute it. So this is another score based on IVUS, which was already mentioned over there. If there's an angiographic calcium present, yes. Then see the degree is more than 270 degrees. Then calcium score, calculation 0 to 4. If it's more than 4, consider atherectomy. And of course the length, the circumferential calcium, nodules, and of course the vessel diameter. So it's very well known that if you look at this curve, the more the calcium, the stent expansion is less. The lesser the calcium, the stent expansion is more. So that will show you, reflect you into your long-term outcomes. So this is one of the algorithms, but we'll not go into detail because it's a very busy slide. But if you look at this center panel over here, you can see that if the calcium score is mild to moderate, then high pressure balloon, and if there's a suboptimal result, you can use lithotripsy and then optimize it with imaging. So if the calcium score is very high, then you can start with orbital or lithotripsy. If the IVL doesn't cross, then again laser is available. Then again the same thing, if there's suboptimal stent balloon expansion, then lithotripsy and stent. And if there's an optimal balloon expansion, then go ahead and stent it and optimize with imaging. So few of scenarios, if there's a mild calcium, and this is how it looks, cutting balloon and high pressure balloon will do the job. And in fact, there is a grading of calcium also, which is somehow missing in this slide deck. Angiographically, you can grade the calcium also as grade 1, grade 2, grade 3 and grade 4. So that's another thing. So if there's a mild calcification, balloon predilation, and if there is suboptimal stent balloon expansion, then you can use IVL or high pressure balloon or cutting balloon. As you can see, the fractures can be visible over here. There can be another scenario where you can have a moderate to severe calcium and there's an uncrossable lesion. So orbital atherectomy or rotational atherectomy is preferred. Then if you have a moderate to severe calcium, uncrossable lesion, orbital or LCA, then if there is suboptimal balloon expansion, then probably lithotripsy would be a good choice. You have this kind of circumferential calcium, then post IVL, you can see this fractures over here. Recently we had 2 cases with calcified, severely calcified SVG grafts, only 3 years old, and very severely calcified. It's amazing. I mean, 3 years they were so calcified. It's like I had to do like a CTO. Then we did imaging and severe calcification. None of the balloons opened, and even the IVL 120 pulses did not open. So we left it on suboptimal result. So I don't know about IVL in SVG grafts. That's one concern out here. So again, so moderate to severe calcium, do the assessment of the calcium score. If it is mild, the score is less than 2, Then it's simple, just high pressure NC balloon, maybe cutting balloon, and followed by plus or minus lithotripsy. So one good thing about IVL is or orbital is you get an lumen gain, which in rotablator you don't get a lumen gain because it's just a superficial debulking. Here you get lumen gain as you see it in orbital atherectomy also. So if the calcium score is very high, then you should be prepared to take care of these lesions with one of these modalities. And of course, laser is there, but not many centers are equipped with laser. So this is how it looks when you do a baseline study: circumferential calcium, then orbital atherectomy, and then stent. So let's go to some examples, and if you can see, this is a very severely calcified mid RCA post cabbage. You can see the clips over there, and yeah, so it was a difficult wiring. So I had taken an Amplat's AL1 guiding catheter for support. Initially we tried with the Judkins, but it was flying all over the place. So we took the AL, and with the help of microcatheter, and balloon was not crossing, and with the help of microcatheter we were able to push the wire down, but the wire went to a certain extent and it just could not negotiate, and the microcatheter was not crossing too. So the plan was to jam the microcatheter in the lesion, which most of the time you are successful. You just jam the microcatheter and slip in a rota wire, and once the rota wire went in, we did the rota over here at 140,000, and it was took a long ablation time, almost 3.5 minutes of ablation time. And then this was, as you can see, this rota crossed, and then we were able to pass a balloon, just pre-dilated it with a 2.5, 3.5 NC, and then as you can see, there's not a very adequate expansion in the center. There's an eccentric calcium at this upper section. So we didn't have orbital at this point in time, and took a cutting balloon, gave some good result. However, it's still not expanded at this point in time. This is 3.5 cutting balloon at 16 to 18 atmospheres. So we didn't do imaging, but we realized that the upper part of nodule is not cracking up. So we ended up doing an IVL in this case. So all the pulses were there. This is the earlier version of IVL with 60 shocks. So with the stent was not crossing, because if you realize there's a lesion in the PDA, PLB and PDA, so the stent was not crossing, then I had to introduce Guidezilla all the way down. This was, fortunately it went down quite comfortably. I ended up putting a first stent in the PLB. It's a big vessel, so that was done. As you can see, there's a tight lesion in the PDA also. So ended up doing a balloon dilatation, and then stented the PDA, and then put another third stent proximal overlapping each other. So this was a final result. I think that was the most what you can get. There's still some probably an under expansion over there, which we did not chase anymore further. So second case is a 65-year-old gentleman, hypertensive, non-diabetic, increasing angina, rest angina last few days. Left ventricular function is normal, renal function is normal. So these are severely calcified osteoproximal LAD going up to the mid segment, and the circumflex seems to be normal. We did a OCT analysis, good landing zone, all the three layers are visible, but however you can see there's a lot of calcium present, deep calcium, and then eccentric calcium also present over here, and then there is some calcium in the proximal segment and a nice landing zone in the proximal segment. So straight away did a pre-dilatation, and the calcium was so extensive. We did a IVL over here in the mid and the proximal and in the ostium, just to show the stent boost how the calcium is seen and the emitters are seen. So this is what I was telling you, when you do an IVL, you get a lumen gain. So this was a lumen earlier, and now you see This is just a post IVL pictures. We didn't do any balloon before before doing the imaging. So cracks are seen all over the place, and this gives us enough encouragement to put in the stents now. So this is a stent which 3.5 stent from the left main into the LED and optimization, and yeah, that was the final picture. So this is another patient which I did. I had done his anomalous circumflex. You can see there's two stents. There was anomalous circumflex coming. He had an acute inferior MI 2 years earlier. So somehow we were not able to see the lesion because the catheter was going in the right coronary artery, and there was anomalous circ which had two lesions which I stented it 2 years earlier. So now he has come with ACS. This is ACS, 2 days ACS, severely calcified, left main stenosis, and as you can see there are multiple stenosis over here. So the TIMI flow was not very good, TIMI 2. So doing Rota, I was not sure. I thought I'll cause more harm than doing anything else. So with my limited experience, I put in a wiper wire, and then this is a orbital atherectomy going in 0.75 and 80,000. So did very slow, very slow atherectomy, and as you can see, there's not much of slow flow, no flow, nothing. It just responded to some couple of ml of nitro and Nicoran. So good result. And then it was just balloon dilatation. And this was a 3.538 drug-eluting stent. And then optimized with 3/12 down, 3.5 in the middle, and 4.5/8 in the proximal segment. So this is the final result. Left main is well expanded. We didn't do imaging because this was ACS situation. So I'll end up with this take-home messages. There are many calcium tools available. Each are needed to be addressed in specific context. The modality of choice depends on calcium score. Higher the calcium score leads to lower stent expansion and increases MACE. Modern debulking devices need adequate training to utilize it to its potential. Calcified lesions most of the time need combination of modalities to achieve the maximum MLA. One must be prepared to handle all kind of complications encountered while using these devices like perforation, stuck burr, dislodgement of stent, etc. Thank you very much for your attention.